Well, welcome to our continuing series on ethics in healthcare in the city of Ventura, sponsored by the Community Memorial Health System. Thank you very much, all of you, for coming here tonight. My name is Dr. Jim Hornstein. I'm the chairman of the Bioethics Committee at the Community Memorial Health System, and it is really my pleasure to moderate tonight's program. Tonight's topic is going to be exciting and challenging. It is titled, Religion and Medicine, Is It a Healthy or Holy Relationship? I know you are in for an exceptional evening because we have amazing speakers and an engaging topic. However, to be blunt, I need to begin by offering an apology. In fact, I have an apology actually to my mother. You see, years ago, quite a number of years ago, my mom taught me never to talk about religion, politics, or drugs publicly. I think she was afraid that no matter what I said or what was said, inevitably you alienate or anger a few or even a lot of people. So tonight, if any of you see her, tell her, I'm terribly sorry, Mom, and in fact, I'm sorry twice, because tonight we will be talking a lot about religion and its important place in American society, and in 2 months, as you see on your chair, we will be hosting our next talk on medical marijuana, on drugs, whether medical marijuana really is a useful medication or whether it's just a backdoor excuse to get high. Either way, religion and drugs in public. So again, Mom, I'm terribly sorry. Truthfully, however, my mom was probably right. These topics can, in fact, be both divisive and alienating. However, our ethics committee chose them not because they are easy to discuss in public, but rather because they are important to discuss. Now, why is it important to discuss? Because for many people, religion defines who we are as a person, how we come together as communities, what is our role in this world, and for many people, significantly, how do we partner with God or with a higher being? For many people, religion serves as a powerful guide to help us make some of the most important decisions we will ever be called upon to make in our lives. And not infrequently, those decisions are forced upon us when we enter into the world that I work in the healthcare setting. And unfortunately, I know from experience that many of you here today, from personal experience, have experienced those kind of very difficult and trying decisions. As we also know, serious illness often brings us face to face with many strong emotions and feelings. Some of those are our most deeply held hopes and dreams, our most dreaded fears, and our most cherished values and beliefs. These concerns about hopes and dreams and fears and values, while they may arise in our hospitals and on our clinics, actually belong more in the realm of religion and spirituality than they do in the textbooks or protocols that I follow in medicine. In the past several decades, our wonderful new medical technologies, and they are wonderful, and they are new, and they are exciting, have allowed us to do all sorts of incredible things to individuals to help their health. Even this past several days, I have inserted a tube into the lungs of an individual to help him breathe easier. That was a medical procedure. However, what medicine alone does not answer is whether we should put feeding tubes and breathing tubes in all patients, especially those who are dying terminal deaths from end-stage diseases. As a doctor, I know how to place a tube in a patient's stomach and artificially feed them. But again, should I do that in a patient who, let's say, has end-stage dementia, who then will spend the rest of their life trying to pull that very tube out? What have we done to help them? Technology alone is not necessarily the answer, and it does again fall to these very important questions of values and goals and fears and hopes. In addition, I've been taught to effectively relieve a patient's suffering, but should I go further, as some people have suggested, and aid not only in relieving suffering, but in aid that patient's death, even if that very patient asks me to help him? I think you get the point. In medicine, just because we can do something does not answer the perhaps more fundamental question of whether we should do something. These questions of should we and ought we do procedures are ultimately answered by trying to understand people's values, their morals, their beliefs, and their religions. And since Americans are overwhelmingly define themselves as religious people, many Americans look to religion as a guide to help answer these difficult and morally complex questions. So tonight, we have the wonderful opportunity to turn to three distinguished teachers to help us better understand how religion teaches us and guides us in the realm of human health, disease, and the difficult choices we will sometimes be asked to make. As has been our custom in these Ethics of Society series, our format is very simple. Each speaker will present their introductory remarks in about 15 to 20 minutes. We will then have an opportunity for a question and answer period, also running about 15 minutes. Now, for those of you in the audience, this is an interactive opportunity. If you can think of a question during a presentation, please raise your hand. You will be given a piece of paper. Fill out your question, and an usher will pick it up from you and give it to me for our question and answer period. After the conclusion of the question and answers, we will then give each of our speakers an additional 3 minutes to give us any final thoughts they have to pull the subject together. So now, if it's okay, and everybody has a seat and something to eat. Everybody have a seat, something to eat? Good. Let's go ahead and begin. Our first scholar is Professor Rabbi Elliot Dorff. Professor Dorff earned his PhD in philosophy from Columbia University and was ordained as a conservative rabbi from the Jewish Theological Seminary of America. Rabbi Dorff has published over 200 scholarly articles on Jewish thought, law, and ethics, in addition to writing over 17 books, which include To Do the Right and the Good, A Jewish Approach to Modern Social Ethics, which won the National Jewish Book Award in 2002, in addition to Matters of Life and Death, A Jewish Approach to Modern Medical Ethics, which he was a finalist for another National Jewish Book Award. Currently, Professor Dorff is the rector at the American Jewish University and is a professor of philosophy for undergraduate and graduate students. In addition, for the past 30 years, he has also been a visiting professor at the UCLA School of Law. Now, in addition to the many other honors and accomplishments, including 3 honorary doctorates, Rabbi Dorff had served on the Ethics Committee of Hillary Clinton's Healthcare Task Force in the early 90s, in addition to testifying at President George W. Bush's National Bioethics Advisory Commission in the late 1990s. Now, in addition to all of these professional accomplishments, Rabbi Dorff is married to his wife Marilyn for 48 years, has 4 children and 8 grandchildren. He volunteers his time freely throughout the Los Angeles and Southern California area, and in my opinion, is probably one of the nicest and kindest persons I have ever known in my life. Ladies and gentlemen, our first distinguished speaker, Rabbi Professor Elliot Dorff.
Well, it's appropriate to apologize to your mother on the night before Rosh Hashanah. when we start the 10 days of repentance. I mean, I guess you ask God for forgiveness, and I suppose also your mother. Absolutely right. Okay. What I'm going to do in these introductory remarks is sort of give you a kind of general introduction to how Judaism understands medical ethics. And I'm going to leave it to the question and answer period for you to ask me some specific questions that are on your mind. So first, two introductory comments. One is, why Jewish medical ethics? What's wrong with regular medical ethics? And the answer is that there's nothing wrong with regular medical ethics. But what we call regular medical ethics in America is based on Western liberalism. Maybe the best way for you to think about this is think about the word religion. The L-I-G in the word religion comes from the same Latin root from which we get the word ligament. Anybody know what a ligament is? Yeah, it's connective tissue, right? And sometimes when a woman has had as many children as she wants, she has her tubes tied. That's called a tubal ligation. It comes from the same Latin root. And what religions do, among other things, is that they give you a big picture of who you are as an individual and who you are in all your connections to your family, to your community, to the larger human community, to the environment, and to the transcendent element of human experience, which in the Western traditions is imaged as God, and the Eastern traditions imaged in other ways. But what each of the various religions does is that it gives you an idea of who you are in all of these connections, and also what kind of a person and what kind of a community you should strive to create, right? So each of the various religions of the world is doing that. And obviously, we're talking about human beings in all of these religions, so you would expect some overlap, but there are real differences among the religions of the world as to what the ideal person looks like. I mean, is the ideal person married, for example? Right? In the Catholic tradition, you have priests and nuns. In the Buddhist tradition, the priests are not married. In my tradition, when I was in rabbinical school, it was all men, and we were told that we'd better get married while we were in rabbinical school, because if we didn't, then the sisterhood would make sure, within the first year that we were in a congregation, that we would be married, and so if we wanted any choice in the matter, we'd better do it now. Okay? That's the other end of the spectrum, right? In the various religions of the world, is everybody supposed to be educated, or are the secrets of the religion held only by the elite, as in Mormonism, or again in Buddhism, right? Whereas in my tradition, already Deuteronomy 31 says, once every 7 years, men, women, and children should hear the Torah read and explained. So my tradition very much sees education as a very important piece of what the ideal community is like. Similarly, you can ask those same sorts of questions. What's the role of work in life? What's the role of play in life? What do you ultimately hope for? And when you do those kinds of things, you see that the various religions of the world have different understandings of this. And similarly, what's the role of medicine in life? Will vary from one religion to another, and not just from religions, but also secular philosophies. Things like Western liberalism, existentialism, Marxism, right? Secular philosophies also give you a big picture of who you are and what kind of a person you should strive to be and what kind of a society you should strive to create. American secular ethics, medical ethics, is based on Western liberalism. Right? We hold these truths to be self-evident that all men are created equal, they're endowed by their Creator with certain unalienable rights, and that among these are life, liberty, and the pursuit of happiness. What am I quoting? The Declaration of Independence, right. Jefferson cribbed that from John Locke, who had written that about 100 years earlier, except that Locke had said life, liberty, and property, and Jefferson said life, liberty, and the pursuit of happiness, and you can imagine how many doctoral dissertations have been written about that one. But I'm an individual with rights in the American understanding of things, right? So therefore, the gold standard in American medical care is, what does the patient want? Right, I've been a member of the ethics committee at UCLA Medical Center since the mid-'80s, and especially on end-of-life issues, the real question is over and over and over again is, you know, what does the patient, or what did the patient, if the patient cannot express him or herself, what did the patient want? And every once in a while, I just can't stand it anymore, so I say, You didn't give him what he wanted through the rest of his life, so why are you so interested now, right? So we laugh about it for 2 minutes and then move on, because that ultimately is going to be the determining factor as to what should happen with a particular patient, right? In the Jewish tradition is much more communitarian, right? It's much more, we are members of a community, a very thick community. And it's not just a voluntary community. In America, you can decide to be part of a community or not. You know, to be a member of a church, synagogue, mosque, whatever, or not. To be a member of a health club or not. For that matter, it's hard to become an American citizen, but if you are one and you have not committed a felony, you can go to any consulate or embassy, American embassy outside the United States, fill out, I think, a 2-page form and renounce your citizenship as an American. So even citizenship is a voluntary thing in America. Whereas in the Jewish tradition, if you were born to a Jewish woman or you converted to Judaism from age 13 on, then even if you later convert to another religion, if you convert to another religion, you're an apostate, so you lose all the privileges of being Jewish, but you still have all the responsibilities. This, ladies and gentlemen, is Jewish guilt, okay, right? Which is very much part of my tradition, although I understand the Catholics really have it. Okay. So I mean, the point that I'm after here is that when you look at the various religions of the world and the various secular philosophies of the world, they will give you different understandings of the role of medicine and the role of health and health altogether. And I'm going to talk about exactly how Judaism understands those things in a moment. But the first thing that I wanted to point out is that why even talk about a Jewish medical ethic altogether? And the answer is because it's different from Western secular ethics. It's also different from Catholic medical ethics, from Lutheran medical ethics, from Buddhist medical ethics, and so on down the line. Second introductory thing that I want to point out is that that medicine has exploded in its ability to do things over the last 100 years. Well, in 1900, life expectancy in this country was, what would you guess? 45, roughly, right? Roughly 45 years of age in 1900. In the year 2000, just 100 years later, life expectancy in this country was 75.8, actually. Let's say 76. So we went from 45 to 76 in 100 years. Now, most of that is not what you read about in the newspapers. Most of that is public health measures. Things like indoor plumbing. My wife and I were at a conference in southern India at one point, and you see all these open sewage pits, and you see flies all over the place, and you sort of wonder why people are not sicker than they are, right? Things like public health education. You're being taught that smoking is bad for you, that alcohol abuse is bad for you, that certainly drug abuse is bad for you and the like, right? And now obesity, right? The various kinds of public health measures, which are not only just educational, but in law. So if you, I still remember I was on sabbatical in 99, 2000. I was teaching in New York, and like page 15 of the New York Times, they had a little article that Maine was the 4th state to ban smoking in public places. But only California, as of 1999, also banned smoking in bars, right? Now, if you make it really difficult to smoke, right, through laws and through things like that, then less people are going to do it. And it has real effects. I mean, there are about roughly now 21% of Americans smoke. The state with the least amount of smoking is, what would you guess? Utah. And now you understand why, right? Okay, 8%, 8.8% actually. But the second smallest amount is California, at 14%, which is obviously a much more diverse population and a much larger population, and that's public health measures, right, that have done this. Similarly, vaccinations that have very much reduced a lot of diseases and things in that order. So it's public health measures that have primarily led to our living longer. Second most important thing is antibiotics. I've had bronchitis 20-some times in my life, and I'm still around, right? Whereas my father had a brother in the United States in the 1920s. He had bronchitis, it became pneumonia, and he died, right? I mean, that's exactly how important antibiotics have been in our ability to survive diseases of various sorts. And it's only really in a tertiary way, if we're talking about numbers, that all of the new things have come into play in terms of why we live longer, things like organ transplants and microsurgeries and the like, right? But my mother gave birth 2 years before me to a baby boy that was a blue baby. What that means is that the wall between the auricle and the ventricle of the heart didn't close at birth the way it's supposed to. And so his oxygenated blood mixed with his non-oxygenated blood, that's made him blue. And he died 2.5 months after he was born. Now we have the surgery for that, right? So had he been born not in 1941, but in 1991, he would still be alive, given that. So the new things are indeed saving people's lives. But if you're talking just statistically, public health measures are the most important thing that have led to that. Second most, antibiotics, and then also these new kinds of things. The question, though, is, if we're now taking an ancient tradition that didn't know about heart-lung machines or didn't know about microsurgery, and you're now trying to apply it to these new situations, you can't just look it up in a book, right? Because the book doesn't know about all of these things, whatever your book is and whatever your religious tradition is. So the question then becomes, does that mean that the tradition has nothing to say about all of these new medical questions? Well, there are three possible answers to that. One possible answer on one end of the spectrum is, if it says nothing about it, it has nothing to say, right? In which case, the advantage of that is that you're being honest. It says nothing about the particular issue. And another advantage with that particular view is that you can do whatever you want, right? The disadvantage of that is that it makes religion completely irrelevant to an awful lot of decisions in life, because it's not just in medicine, it's also in, tradition doesn't know about the internet. It doesn't know about business deals done by the internet. It doesn't know about, iPhones and all of that. So if you're going to take that position, that if your tradition says nothing about a given issue, that it has nothing to say, you're going to make religion completely irrelevant to an awful lot of things in life, which is very problematic, because you look to your tradition for at least some moral guidance. The other end of the spectrum is turn it over and turn it over again, everything's in it. In other words, by hook or by crook, you're going to interpret your tradition to give you guidance on all kinds of things that never even contemplated. The advantage of that is that then you get a linkage between your tradition and whatever the issue is, right? So your tradition becomes relevant to everything. The disadvantage of that is, number one, you're being dishonest about your tradition. The tradition really didn't say that. And what you really are doing is what's called eisegesis instead of exegesis. You're reading into the tradition whatever it is you want to read into the tradition. So you're not getting any guidance from your tradition. You are just making your tradition say what you want it to say. You follow what I'm talking about? So those are the two ends of the spectrum. And what I would argue for in this book, Matters of Life and Death, in the appendix, is for a different way of dealing with this. Namely, that sometimes, at least my tradition, has some very specific precedents about certain medical issues. Okay? It has very clear precedents about the status of the fetus, for example, that go back to the Torah itself. Let alone later rabbinic understandings of things. But in a lot of cases in medical ethics, it doesn't have precedence. So then what do? Well, then you do what I call depth theology. That is, you look to the underlying principles of the tradition and the underlying commitments of the tradition. How does it conceive of things, and what are its values? Right? You look at the underlying concepts and values of the tradition, and you apply those. Okay? So then the question becomes, well, what are the underlying values and concepts of the Jewish tradition vis-a-vis medicine? In the second chapter here, I talk about 7 of them, but tonight I'm just going to talk about 3, just so that you get a sense of what this is about. So one underlying principle of Jewish medical ethics is the body belongs to God. Okay? Now this is already different from American secular ethics, because in American secular ethics, to whom does your body belong? To you, right? And you have the ability, this is the Nancy Cruzan decision of the Supreme Court in 1990, if you are an adult, you have the ability to refuse all medical treatment. You may not do that for your children, that's a whole other matter, okay? But for you yourself, you have the right to refuse anything. You don't have the right to demand everything, That's a whole other matter, right? But you have the right to refuse anything because your body belongs to you, okay? And that's why what does the patient want becomes the gold standard of American medical care, right? In the Jewish tradition, God owns our body. We have it on loan. We lease it, actually, during the course of our lifetime. So it's as if you were renting an apartment, okay? You have, on the one hand, you may not destroy the apartment. Why may you not destroy the apartment? Not yours. And of course, the medical analogy would mean you may not destroy your body. You may not commit suicide, okay, because it doesn't belong to you. Similarly, you may not damage or injure your apartment any more than normal use would require. So in the medical analogy, you take risks in life. What kinds of risks may you take? May you go skiing? Well, yes, because even though there are injuries, there are injuries that come with skiing and sometimes even death, right? But by and large, if you learn how to do it and you stay on the paths that are marked, you're fairly safe. May you go bungee jumping? Well, that's a stretch. I couldn't resist. Right. Actually, bungee jumping is safer than skiing is. But you understand the point. I mean, but a more serious question is, may you drive a car? Right? I mean, that's frankly more risky than either of the two above, right? And so part of the issue is, how do you define the risks that are acceptable in your life that God would allow you to do? And the basic idea is, if it's risks that many people take and are safe with it, then you're allowed to take those risks, if not, not. Okay? But you're not allowed to damage the apartment. On the other hand, you have obligations to take care of this apartment. So rules about proper diet, exercise, hygiene, sleep. In the American understanding of things, why should I exercise? Because I'll feel good. What else? I'll live longer. What else? I'll look good. I'm maintaining yes, okay, good. Right, I am maintaining the apartment. That's exactly right. I also, by the way, will have, I'm more likely to be employed. We know that now, right? Because my health care insurance will probably be less, okay? People will like me better if I'm fit than if I'm not. All kinds of practical reasons. This is American pragmatism at its height. Practical reasons why I should do it. But if I don't want to do it, let's say, all right, here's my Achilles heel. I want to eat a half a gallon of ice cream every night of the week. And if you're doing it, it might as well be mint chocolate chip, right? Or cherry Garcia. That stuff is so good. Anyway, all right. But I will gain 500 pounds in no time. And there is no American law that says I may not eat a half a gallon of ice cream every night of the week, right? I might be stupid. Okay, but there's no law that forces me not to. On the other hand, in the Jewish tradition, I have an obligation to God to take care of my body. So that means things like proper diet and exercise are things that I must do even if I don't want to do them. So I have to avoid that half gallon of ice cream either by never buying it in the first place. That's the really important thing. Or by avoiding it simply because I have a duty to God, a fiduciary duty to God to take care of this apartment of mine called my body. All right? So you can see some very different understandings of things if my body belongs to me or my body belongs to God. Second underlying principle, we are integrated wholes, we human beings. Now, our body, our mind, our emotions, our will are all integrated within us, and they affect each other. Now, you might say, well, that's obvious, but it's not at all obvious. If you look at Western philosophy, starting with people like Plato, there is a major dichotomy between the body and the mind, right? The body in Plato is the animal in you. The mind is the distinctly human in you. And they are completely separate, one from the other. So much so that in Western thought, a standard issue is the mind-body problem. Namely, if the mind and the body are separate, how are they at all connected? Descartes thought that they were connected in the pineal gland. It's a gland in your head. That was the magic place where the mind and the body were connected. But to this day, I took a course when I was in graduate school on the mind-body problem, and you get all kinds of issues as to how they are connected. And to some extent, this really affects medicine in a way that I'll just show you in a moment. But in the Jewish tradition, well, I'll tell you a story in the Talmud. A man has an orchard. He leaves it in the watch of a blind man and a lame man, and he says, "Don't eat of any of the fruit of the orchard." So, and then he leaves. And then the blind man says to the lame man, "This is easy. I'll put you on my shoulders. You'll show me where to go. We'll eat of the fruit of the orchard. He'll never figure out how we did it." So that's what they do. The owner comes back sometime later and sees that some of the fruit is missing, and he says, "I thought I told you not to eat of any of the fruit of the orchard." And the blind man says, "I couldn't possibly have done it. I can't see where it is." And the lame man says, "I couldn't possibly have done it. I can see where it is, but I can't get there." So the owner takes the lame man, puts him on the shoulders of the blind man, and says, "This is how you did it, and this is how you will be judged." Similarly, says the Talmud, the body says, "I can't possibly lead a person to sin, because without the life breath within me, the neshama within me, I can't move. I'm simply like an inert stone." Okay, and a stone can't sin. And the life breath within one, the soul, if you will, right, says, "I can't possibly lead a person to sin, because without the body, I'm just like an ethereal bird that has no substance whatsoever." So God takes the soul, throws it into the body, and says, "This is how you were created, and this is how you'll be judged." Now, it's a simple story, but what it does is that it articulates a Jewish understanding of things as being, we are completely integrated, which means what? That the way we think and the way we feel and what we desire all affect our physical being, and vice versa. Our physical being is very much connected to how we think, feel, and will. And so consequently, when you're doing medicine, what does that mean? It means you're not, if you're a doctor, simply treating the body. You're treating the patient. You're treating the person as a patient, right? And you have to find out from the patient all kinds of things that are not directly connected to the body in order to be able to do good medicine, right? That, of course, takes time, and that's really problematic in the contemporary economic environment. But there are all these studies that have been done recently about American medicine where patients don't trust their doctors because their doctors are there for literally 5 minutes sometimes, right, and are listening for about 12 seconds, right? That's an exaggeration. It really is. But still, I mean, there's no leisure that doctors have under the current economic conditions for actually finding out what's going on. And the patients who end up trusting their doctors are the ones who think that their doctors have actually listened to them. Okay, but that takes some time. And by the way, good medicine, good diagnosis also takes some time, because some of the things that the patient will tell you only 10 minutes later after the beginning of things, right, turn out to be the really important things about the patient's physical condition. And also, by the way, we have some very good evidence. What percentage of simply prescriptions, I'm not talking about hard things like going on diets or stopping smoking, but simply prescriptions for pills. What percentage of prescriptions for pills do you think patients actually fill and take? Yeah, about 50%, okay? Now, some of it has to do with language problems. The doctor's speaking English and the person is speaking some other language. But a lot of it has to do with the doctor never had time or never did explain why you're taking this, right, and what it's supposed to do. Some of it is the doctor never realized that you don't have the money to buy it. Okay, all of those kinds of things, right? So seeing the person as an integrated whole and as a patient is really important in medicine. I was on a curricular committee for UCLA Medical School in the early 90s, where they created a program called doctoring, which is required of all medical students at UCLA for all 4 years of medical school. And what it is a series of vignettes in which the medical students are interacting with people who come with different things, right? So I remember the first one we created was a 15-year-old woman, I should say, who complains of stomach problems. You are the doctor. You diagnose her, and she doesn't have stomach problems at all. She's just pregnant. Okay. Now, if she were 18, it would be better, and if she were 12, it would be much worse. Okay, but she's 15, otherwise in good health, but she is Hispanic and Catholic and unmarried. And so all of the issues that have to do with her health and that of her fetus have to do with the fact that she is Catholic. Does that mean that an abortion is out of the question? Probably, but you never know. I mean, I'm co-chair of the Priest-Rabbi Dialogue in Los Angeles. I've been part of it since 1973, and the American Church is the Pope's loyal opposition, as my priest friends say. But probably an abortion is out of the question. She's Hispanic. Is she going to get kicked out of her house? And if so, where is she going to have this baby? Probably not in the Hispanic community. She probably won't be kicked out of her house. In other kinds of Catholic communities, she might be. You had these homes for unwed mothers and all of that, right, in years past. And she's, she's single, clearly. So where is she going to have this baby if she's going to have it? What is she going to, is she going to give it up for adoption? Is she going to keep it? Where's the man in all of this? Right? All of those things really matter in terms of her own health care and in terms of that of her fetus. Similarly, on this issue of being integrated wholes, right? Not only within yourself, but within your community. So what does that mean? That means in the Jewish tradition, for example, there is a commandment that you have to go and visit the sick. Now, why is it that you and I, and I'll say it straight out, that you and I don't like to visit the sick, especially when they're in hospitals? Why don't you like to do that? Staph infections, absolutely right, okay? Probably the most dangerous place to be for that. Why else don't you want to do it? Depressing, good. Why else not? I'm sorry? It's frightening, yes. Go ahead, why else not? You don't know what to say, which I'm going to come back to in just a moment. Exactly right. And then, of course, there's the schlep of it all. Right? You have to go to the hospital, you have to pay for parking, you have to find out where the patient is, and then when you get to the room, what's likely to be the case? They're out for test or they're sleeping, right? In which case, they're not encouraged to come back. But let's say the person is indeed awake, okay? So then the question is, what do you say and what do you do? The Jewish tradition actually has some very important advice. Number one, sit down. And doctors here, watch this. Why? Because if this is the patient and this is you, what does that body language say? I'm superior to you. I'm in power. You're not. That's the last thing you want to say to a patient. So you're supposed to sit down. Actually, before several centuries ago, people were lying on beds, on mattresses on the ground. So you were, the text, Maimonides, who was himself a physician, 12th century, says you actually have to lie on the ground so that your head is not above the patient's head, okay? And then, what do you talk about? Well, you talk about the same sorts of things that you would normally talk about if the patient were well. So if you and the patient share an interest in sports, talk about that. Movies, books, communal business, synagogue or church business, whatever, talk about those things. What are you saying to the patient when you're talking about those things? Yeah, first of all, you are an adult, and I'm treating you as an adult. Second of all, even if your prognosis is terrible, at this moment in time, you and I are interacting as adults. And that I really take your position very seriously. Because illness is, first of all, isolating, and hence the commandment to visit, right? Illness is also debilitating, and therefore sit down and don't reinforce that sense of disability. Illness is also infantilizing. Right? And so you want to talk about adult things, not, just take my word for it. Both patients and visitors tire of talking about the food and the weather in about 3 seconds. Okay? So you talk about that. You talk about things that you would normally talk about. And finally, illness is boring. Right? So if you have a long-term illness, most of us are going to die of long-term illnesses and not of acute illnesses. Right? So, but if you know that people are coming today to talk about the things you like to talk about, then that's a reason to get up in the morning, right? So you need to, so this notion of visiting the sick is also part of this whole idea of the person as an integrated whole. And then finally, the last thing I'm going to talk about tonight before the questions, the third underlying principle is that medicine is a good thing. That it's not the case that if we do medicine, we are taking away God's prerogatives, as some traditions understand it, but rather we are the partners and agents of God when we help people stay well, first of all, prevent illness, and also when we cure illness. And so consequently, the Talmud ultimately says that a a Jew may not live in a city that lacks a physician. Because if you live in a city that lacks a physician, then when you get ill, you cannot get professional help to take care of this body of yours that belongs to God. So Jews have had a virtual love affair with medicine for the last 2,000 years. A lot of rabbis who were also physicians in the Middle Ages. It doesn't happen very much anymore because rabbinical school still takes more or less the same amount of time, but medical school takes much, much longer. I was at a conference at the University of Virginia where the dean of the medical school said that in Mr. Jefferson's medical school, how long do you think it took to become a doctor? 1. Okay, because in the 1700s, that's all they could teach you, right? Now it's 4 years of medical school, 4 years of pre-med, 4 years of medical school, a year of internship, 3 years of a residency, and very often a postdoc, right? So going to rabbinical school and medical school doesn't happen very much anymore, right? But there is a very strong sense in my tradition that medicine is a sacred profession. And that and that therefore, for many years, every Jewish couple wanted to have their daughters marry doctors. Now their sons marry doctors, right? So I mean, there's a very strong sense of medicine not being taking away God's prerogatives, but rather being the agent and partners of God in promoting health. I'm going to be happy to take all your specific questions when the question and answer period comes up. And
Our second speaker is Father Dr. Luke Dysinger. Father Dysinger is an expert in Catholic moral theology and church history and is a professor at St. John's Seminary in Camarillo, which, by the way, has a front page article in the Ventura Star today. If any of you want to learn a little bit more about the seminary which Father Luke works at. Professor Dysinger received his bachelor's degree in religion at the University of Southern California. I did not know he was a Trojan prior to here. And he went on to graduate from medical school also at USC School of Medicine. He crossed a chasm and did part of his residency at UCLA and completed an interfaith experience, right? He completed his residency in family medicine and was board certified by the American Board of Family Physicians. Not quite through with his schooling, he crossed the Atlantic to attend Oxford University, where I don't know if they have a football team, but we call it soccer, right? But where he received his doctorate in philosophy in theology. He's the author of dozens of scholarly publications and teaches academic courses in marriage and human sexuality, healthcare and Catholic morality, and bioethical dilemmas at the beginning of life. In his spare time, Father Dysinger is an instructor in medical ethics for all the Catholic priests practicing in the Southern California area. I think you would all agree that as a doctor, professor, and priest, Father Dysinger is exceptionally qualified to teach us all about the Catholic perspective on healthcare and human illness. Ladies and gentlemen, Dr. Dysinger.
Thank you very much for the opportunity to follow Rabbi Dorff. Many of the things that he said about the development of the tradition and reflecting on ethical issues means that I can quite easily dovetail into that by saying that the Catholic tradition of healthcare ethics, what has subsequently come to be known as bioethics, has been going on for a very long time. Very early Christian theologians, already in the 200s and the 300s, were taking advantage of rabbinic reflection on questions like, when does life begin? How should we cherish life in the womb? Jews and Christians in the Roman Empire were known as being exceptional because they did not expose their infants. They did not believe that they had the right to kill children who had obvious defects of one sort or another, or who were of the wrong gender overwhelmingly being female. So from a very early stage, Christians reflected on the significance of life, and several principles became rather foundationally enshrined in subsequent documents and tradition. One is that life is a gift. It is not something over which we have control. God gives us life as a gift, and when life occurs in the context of marriage, it is also a gift, not a right. So the Catholic tradition would always emphasize the tremendous responsibility we have to safeguard, to take responsibility for the great gift that we have been given in our own lives and in the lives for which we may become responsible, particularly as parents. And another foundational principle, which is found very early on and continues to be reflected on throughout the Middle Ages and is clearly articulated today, is that the taking of innocent life is always wrong. There are no circumstances that can justify the direct, intentional taking of innocent life at any stage, whether at its end or at its beginning, because life is a gift from God. So, another vitally important and fundamental principle, which is even evolved into the question of a kind of a moral, ethical principle called the principle of double effect, is that we cannot ever deliberately intend to kill, but we must be aware that many human acts, all human acts, have multiple consequences, not all of which we can control, and that there may well be actions that are required, that are essential, which will have unintended secondary effects. And therefore, one can engage in acts intending to help, which may have a secondary effect even of causing death. I say that because it will kind of underlie principles connected with the beginning of life. But I'd like to focus this evening, and I suspect in our questions we may actually raise beginning of life questions. I'd like to focus on the, if you will, magisterial or official position on questions concerning the end of life that have been reflected on over a number of centuries. Questions like, are we always obliged to do everything that the doctor tells us we should do? The answer is no. And in fact, that conclusion was reached many centuries ago. Medieval theologians and in more recent time, Renaissance theologians considered the question in all of its ramifications and came to and continue to come to the same conclusion. You are not always obliged to do everything your physician says just because it's been recommended to you. We'll look at why that's the case in just a moment. The other vitally important question that one has to be aware of, and it's enshrined in some of these documents, is that life is a gift, and we are given responsibility for that gift, but we always act in freedom and with an informed conscience. Our actions are always intended to be engaged in a way that is as free as possible, as free from compulsion as they possibly can, and as informed as they can be by the various options that exist before us. And because life is a gift, because life is a precious gift from God, we're required to honor and to steward it. What I've given, for those who might wish it, on a little handout is an official statement from two parts of official Catholic teaching. One is the Catechism of the Catholic Church, which is not just a document intended to educate children, but is intended to be a compendium of doctrine drawing from the full 2,000 years of Christian tradition, crystallizing out many vital and central issues. And I've encapsulated a couple of points from the Catechism here before us, which might be rather different from what one imagines the Catholic Church teaches. Life is a gift. Life is a precious gift. We are required to steward it. But the other essential insight that characterizes Christianity is that life does not end at death. All of us are intended for an eternal destiny in which we will live in intimate union with God and one another. So if you don't like your neighbor, you better start. And in fact, some of the best definitions of what unpleasantness in the world to come might consist in are precisely meditations on exactly that question. When Jean-Paul Sartre said that hell is my neighbor, he was articulating exactly a concern that people today have. If your desire is to live in absolute and complete freedom and isolation from others, I'm sorry, you're in for a disappointment in the world to come. Catholics are convinced that we will live in a deepening union with God and with one another, and we begin now to live in a part of that unity and that union. So the choices we make involve both one another and they involve our relationship with God. And in regard to the end of life, there's a very foundational and fundamental principle that might be a little surprising to some, and that is that discontinuing medical procedures, and this is something that was talked about already in the 15 and 1600s. This is not a new principle. Discontinuing medical procedures that are burdensome, dangerous, extraordinary, or disproportionate to the expected outcome can be legitimate. In other words, you are not always required to do what your physician tells you to do if the consequences will involve burden, danger, and the word extraordinary is used, but there is no Vatican list of what is extraordinary and what is ordinary. That word depends upon the individual. And often the phrase morally repugnant is used to describe the fact that if a person has a profound and deep-seated revulsion about something that is being recommended to them, that may well be a legitimate reason for them saying, I'm not going to do that, even if it might hold the potential for sustaining or extending life. So it can be legitimate. It's the refusal of overzealous treatment. And notice the statement that follows, one does not will to cause death. One's inability to impede it is merely accepted. Because finally, we recognize we cannot keep ourselves from dying. We will all die. It's a question of what is morally and ethically expected, required, normal for an individual who has reached the end of life. And Catholic moral teaching would say very clearly and very specifically that as the end of life approaches, the obligation to do anything you don't like diminishes drastically. People at the end of life have the right to refuse anything they experience as burdensome or disproportionate. I do not define what is a burden for you. You can tell me what the burden consists of for you. Again, this is not some, theological opinion from a liberal theologian. It's from the Catechism of the Catholic Church. I wanted to point out one little phrase that is of particular importance, especially for Catholics who become nervous and worried when they think that the world is becoming a more dangerously liberal place. People were talking some time ago about a fear of death committees that might be created by the government to insist that certain people not receive care. And unfortunately, I'm afraid there has been a linking in some people's minds of the idea of committees that would refuse care with something absolutely fundamental and beautiful, namely palliative care. Treating a person's pain, discomfort, and experience of loss, especially at the end of life, with whatever that person needs in order to be kept comfortable. Palliative care is about treating symptoms, not about curing diseases, and the Catholic Church's approach to palliative care is here. Palliative care is a special form of, this is a very bad translation, disinterested charity. Disinterested means non-selfish. It means a love that proceeds from generosity. The Latin word is gratuitas, gracious charity. Palliative care is a form of loving. And if we could switch to the other slide, to the other text. Again, this is for anybody who might want it in a handout. This is from another kind of document that was assembled not by the Vatican, which the Catechism was, but by the North American bishops. And it's called the Ethical and Religious Directives Concerning the End of Life. And here too, it's very clear, and it's restated, a person has a moral obligation to use ordinary or proportionate, meaning it's likely to do you good, it's likely to achieve the ends that have been described, means of preserving life, But proportionate means are those, and I've underlined, that in the judgment of the patient offer a reasonable hope of benefit, do not entail an excessive burden, or impose excessive expense. One can refuse care because it costs too much. This is a principle that was enshrined centuries ago, where people asked, if I want to leave a legacy to my children, and the physicians are telling me that I have to sell my property in order to take care of my health care needs, am I obliged to continue living at the expense of what I would pass on to those I love? And the Catholic answer to that was, no, you are not so obliged. Expense can be a reason for choosing not to undergo therapy. That sounds a little odd and a little un-American. But again, for certain individuals, that would constitute a significant burden. Well, we could go on and discuss these matters in a great deal more detail. The question of nutrition and hydration, the Catholic Church got a bad rap a number of years ago when the LA Times and other periodicals began misquoting a papal document that was intended to describe only the situation of the persistent vegetative state, a specific medical condition, which Catholic theologians and people throughout the world regard as a state of being profoundly disabled and in which a person should receive nutrition and hydration. The conclusion was, okay, Catholics always have to die with feeding tubes in place. That is false. No one at the end of life who experiences forms of medical care as burdensome, painful, expensive, morally repugnant is obliged to use them. And having said that, I think I'll wait till the question and answer period to carry on a little further. Thank you all very much.